All right, this is Sports Medicine. I'm Shane Shapiro from down the road in Jacksonville, Florida. I have no relevant financial disclosures. We've got a great panel for you this morning to kick things off. I'm going to briefly outline how we're starting to use stem cells in sports medicine, go over very quickly some regulatory concerns, and maybe just a little bit of science to go along. Then I'm going to turn the podium over to my colleague Stephen Sampson, who's with the Orthohealing Center out in California, and he's going to talk a little bit more about how we're using this and do some case presentations. Then we've got two folks who are on the front lines of sports medicine, Ron Courson, who's the director of sports medicine at the University of Georgia, and Malcolm Mitchell, who's a varsity athlete at the University of Georgia and has some personal experience with sports injuries and regenerative medicine. So the regenerative medicine really is the holy grail of orthopedics and sports medicine. What we're really talking about is repairing damaged tissue, preventing further degeneration, getting back to competition quicker, faster, and this started with our early work in platelet-rich plasma and then has now progressed to stem cells. So this is a discussion of stem cells and not platelet-rich plasma, but the way most of us got involved in this was about 10 years ago. A regenerative technique called platelet-rich plasma exploded on the scene, and this really came to the forefront in 2008 when two members of the Pittsburgh Steelers were treated with platelet-rich plasma just before the Super Bowl and 2 weeks before the Super Bowl, and were still able to compete. So what is platelet-rich plasma? It's this density gradient centrifugation of venous whole blood down to its three components: red blood cells, plasma, and then the platelets, which contain healing cells. And so we were able to harness this technology to try and promote healing of damaged tissues. And another advancement that Dr. Sampson's going to talk about is our ability to use image guidance to precisely deliver healing cells to areas of injury. So here we've got a cross-section of an Achilles tendon that's torn, and I can bring my needle in here under ultrasound guidance to deliver our growth factors to that area of torn tissue. So it was from there that we were able to progress to concentrating bone marrow. Now, bone marrow is very similar to PRP in that it contains growth factors, it contains cytokines, but unlike PRP, it has higher numbers of mesenchymal stem cells, which may hold the promise for faster tissue regeneration or even better tissue regeneration. Dr. James Andrews, who's a noted orthopedic surgeon and was involved and helped pioneer the last big thing in sports medicine, which was arthroscopy, seems to think that stem cells will be the next big thing in sports medicine. And certainly numbers of media outlets have reported that athletes of all skill levels and all ages are pursuing these regenerative techniques. But with so much that's out there, it can be hard for patients and for physicians and scientists alike to know what's the truth about stem cells in sports medicine and orthopedics. So we're going to try and touch on that, a little bit about vocabulary if you're not familiar with it. We have stem cells in all of our tissues. They roughly break down into hematopoietic stem cells and mesenchymal stem cells. The hematopoietic stem cells go on to form blood products, and mesenchymal stem cells can form bone, cartilage, fat, ligament, tendon, and so on. So the MSCs are the ones that we in sports and orthopedic regenerative medicine are most interested in. Okay, so here's a couple of the abbreviations you might hear us talking about in the course of the next hour. All right, so what is this bone marrow aspiration and concentration? If you'll bear with me, I'm going to try and show you a video that won't play through the PowerPoint, but we may have figured out a way to make it happen. Maybe, maybe not. So what we do with the bone marrow aspiration and concentration is instead of taking venous whole blood from the patient, we take bone marrow. And bone marrow can come from a couple of places, but we're currently using the posterior aspect of the iliac crest, so like the pelvic bone. And a little bit challenging to harvest, but we are able relatively comfortably to pull out a good quantity of bone marrow, and then we take the bone marrow over to our centrifuge and process it the same way we do the platelet-rich plasma, which is density gradient, and it separates it again out into three components, with that cellular component being very similar to platelet-rich plasma, just containing additional mesenchymal stem cells. Okay, so now with a little bit more of a complex technique, we can improve perhaps the regenerative capabilities of this modality. Now, it is worth mentioning that even the bone marrow, when we concentrate it, are still relatively low numbers of stem cells, not nearly the quantity that we could get by culture expanding stem cells, but still stem cells nonetheless. The marrow of individuals differs from person to person, so you can get variable numbers. And so we're still learning about this technique, but there's a number of different systems that have been brought to market that give us the capacity to harness these stem cells. All right. Now, the good news is it would seem that as far as the FDA is concerned, the bone marrow aspiration and concentration is covered under 361. So these are the Code of Federal Regulations, 21 CFR 1271, and 361 requires that you have a biological product that's minimally manipulated and is still for homologous use. And this used to be a murky gray area where we weren't quite sure whether this was covered under the practice of medicine or whether this was a drug to be regulated by the FDA. A recent high-profile court case and newly released FDA guidance documents have helped shed light on this and clarify how we can use these cells. So these are just guidance. They're not legally enforceable just yet. But we're starting to see where the bone marrow fits in, where stem cells derived from fat fit in, and other sources. So minimal manipulation means that we're processing the tissue, but we're not altering the original cellular characteristics of that tissue, and that we're also not combining these substances with any other substance. And so in their draft guidance for minimal manipulation, the FDA actually cited peripheral blood stem cells that are not altered with regard to their relevant biological characteristics. And so those of us in the field believe that this is good guidance, that we can use these cells in a regenerative capacity to treat our orthopedic and sports injuries. Well, how about fat? Because we've heard about the bone marrow, and many people would make the case that fat stem cells are more abundant, and perhaps harvesting fat is a little bit easier than harvesting bone marrow stem cells. Everybody's willing to volunteer for a little liposuction. Not everybody's willing to volunteer for a bone marrow aspiration. So here we have a machine that does a similar process where we can put our fat in up top, and it'll separate it out into three components. It separates the cellular material from the adipose material and leaves us with something we call stromal vascular fraction, which contains the growth factors and the stem cells. Now, it does not seem with the most recent guidance that this would fit into homologous use, and so this is hot off the presses. This is October of 2015, that essentially states that when using fat, you have to trade fat for fat. So fat, as far as the FDA is concerned, is a structural product that provides cushioning, and it also provides storage. So that if I'm using a stem cell from fat to regenerate cartilage or some other injured orthopedic structure, I am not using it in the same basic function that it came from in its donor site. And so again, in that document, the FDA gives examples of the stromal vascular fraction and how the FDA considers it not only more than minimally manipulated, but also non-homologous use. So I would encourage anybody interested in this field, all stakeholders, to take a look at those documents at some point and do a deep dive into them and really get to the bottom of what the FDA thinks about these treatments and these processes. We also have amniotic derived products. The amniotic derived products have been promoted over the last year or two. Really a lot of growth in that even since we were here last year. These are stem-like products, the FDA wants us to call them, and that's because they may not actually contain any stem cells. Frequently they can be found in a bottle, and the material can be reconstituted with saline and used for injection like we would inject our bone marrow stem cells or our fat. They contain growth factors, just as the platelet-rich plasma and the mesenchymal stem cells do, and they may in fact be easier to use than the MSCs because they're readily contained in a bottle, and we can just dial up the dose that we need for the particular condition that we need. Unfortunately, again, the FDA has been rather clear in the October homologous use document, which states that the amniotic cells are to provide an environment in utero, and that using them for other purposes, surgically or to repair or replace bone defects, is not homologous use. Cord blood is another source of cells. There's actually some ongoing clinical trials in this country right now that are investigating stem cells from cord blood products, and so we'll be very interested to see how these clinical trials come out. So as it stands in 2016, I am not aware of any FDA-approved biological license for a mesenchymal stem cell product. There's one license out there for a hematopoietic stem cell product that I know of, but we're still working towards one day having the option of pulling something off the shelf that we can use to treat orthopedic and sports injuries. So I've put together this slide that I'm gonna close with, because I think it's important for us all to think about when you look at all the different advertisements out there and the different marketing campaigns. What is available to us right now? That's really what we're here to talk about. Well, I mentioned the bone marrow derived stem cells. So that bone marrow concentrate, or what I call BMAC, readily available using multiple systems, and a number of practitioners have started using this in their practice. It goes by a bunch of names. I'm not sure any of us know whether or not any of these are different from one another. That will be studied at some point, and shows a lot of promise in our early research studies for being a nice pain reliever and possibly a healing agent. If you go to start culture expanding either bone marrow or adipose, you're into an entirely different set of issues. We have the FDA regulatory concerns, and then there's concerns of what we call stem cell tourism, which is because we don't have this available to us in this country, our interested patients may be leaving the country to pursue these elsewhere. The FDA obviously does not regulate overseas clinics. There have been a number of, unfortunately, patient deaths related to stem cell treatments overseas, so we're all very much concerned about that. A lot of promise for the adipose-derived fat cells, whether they be same-day enzyme digested, the stromal vascular fraction, or whether they be culture expanded. And then if you go down to the bottom, we have the platelet-rich plasma and what some people are calling venous-derived stem cells. We have the amniotic products, or the stem-like. There's a number of names here that hopefully will be investigated in the coming years. And then these products that are already in development, Cardistem and Osiris, two products that have already been studied under FDA INDs. These are allogeneic stem cells and seem to show a lot of promise. So with that, I'm going to turn it over to Dr. Sampson, who is going to tell us a little bit more about his practice and how he's using regenerative medicine on a daily basis.
Okay. First, I just want to say thank you to Bernie and Julie for the opportunity to be here. Hopefully you can hear me. And being a part of this event really echoes my overall philosophy, which is about collaborating with doctors, industry, and as we learned this morning from some of the FDA talks, patients and patient activists. And I look at us all as pioneers. This is all really new and we're part of history. And I want to share my brief story in biologics. I want to talk briefly about osteoarthritis. While this is a sports medicine session, arthritis is an epidemic affecting younger individuals in their 30s and 40s, and many are not aware of this. And then I'm going to discuss some case studies and some new therapies we're working on. So in my former life, I used to travel around the world and even get in a grass skirt with villagers and explore new areas and challenge new ideas of thinking. And I went through medical school afterwards, and it was a pretty straight and narrow path between taking your boards, route memorization, passing tests. And once I got into clinical medicine, I began to discover a whole new realm requiring both art, creativity, and science. And so finishing residency, I had first worked with the US soccer team with some of the orthopedic surgeons. And I learned about PRP, this concept Dr. Shapiro discussed, being used in Spain to accelerate healing and injuries, especially with ligaments of the MCL. And so in August of 2007, after treating soccer athletes, I tried surfing and tore my own MCL and experienced firsthand the therapeutic benefits of PRP. This inspired me to really look into PRP, and at the time there was no published literature of it for musculoskeletal orthopedic injuries. And so I published one of the first reviews, and then I started thinking, well, if we're using it for tendons, perhaps why not joints? Initially we thought hemophiliacs, we know it causes chondrolysis or cartilage damage, but there was some therapeutic benefit through PRP, why not in joints? And we did one of the first pilot studies showing it had early promise. And this led us into, as Dr. Shapiro had mentioned, bone marrow concentrate and other cell therapies. And then after lecturing around the world and meeting different scientists and creating new ideas, we continued to expand what we're doing. And so 7 years ago, I founded what's called TOBI, which stands for the Orthobiologic Institute, which is a great symposium where we have over 500 attendees from 25 countries. And we merge veterinary stem cell scientists, PhDs, clinicians, orthopedists to advance the field and provide further credibility and standardization, which is really lacking. My practice is in Los Angeles, California, and we treat acute injuries, and we're a frequent consultant for the Los Angeles Clippers and the NBA, as well as USA track and field athletes that train locally. And then we have many chronic athletes that come from around the world, especially soccer players from South Africa. And the bulk of our practice is really weekend warriors, everyday patients. So this is just a great slide that shows our typical patient population. People are really nowadays defying the norms of activity. You have seniors playing basketball. This is a male in his lower 70s pole vaulting competitively. A man drag racing in the salt flats. The man on the far right had PRP and we called to see how he's doing, and in a short period of time he sent that picture of him running. But we know that when you injure a meniscus or an ACL, we heard from the FDA speaker this morning, biomarkers. There's a spike in proteins in the serum in your knee that will inevitably lead to osteoarthritis. And so we partnered with the Arthritis Foundation and the American Osteopathic Association, and in February I'll be testifying in front of Congress to really inform them of the need to address this epidemic of arthritis in young, especially in the military. It affects 1 in 4 servicemen and women versus 1 in 5 in our patient population. Why? They're subjected to meniscus, ACL tears during boot camp carrying heavy packs. And years later, they'll develop arthritis without a doubt. So we need to understand arthritis isn't just the simple grandma, grandpa, bone on bone. There's a biologic process occurring within the knee that's affecting our treatments. And there's many people in this gray zone where they're too young for the gold standard of a total joint replacement. And there's a huge void where we need better options. So many of these people that are considering a joint replacement in their 50s or even 40s or 30s are setting themselves up for a bad situation because they have poor success rates in younger individuals under 60, and they're prone to revision that have poor outcomes. So if we just pause this concept, and it's really a paradigm shift in medicine, We're cellular beings. Each and every one of us is a universe of cells made of, on average, 37 trillion cells at any point in time in our body. So I put the question, what if? What if we could introduce specific cells, healthy cells, to turn on our body's own innate healing process? We can all understand our bodies can self-heal and repair. We've had a bruise, a cut, a scrape, or a wound that had its ability to heal. But as we mature with time, that ability gets compromised. And so this concept of cellular medicine has great promise in fundamental science. When we understand arthritis, for example, what's happening? I tell patients, imagine you're putting a drop of water in a cup. Drop, drop, drop. One day you may do one activity you've done regularly, and suddenly you have a dramatic injury. The body can't sustain the daily trauma, and it's a failed healing response or a failed cell response. And so without getting too scientific, we know it involves your immune system, which leads to changes in the joint fluid that changes the growth factor to become pro-inflammatory. It's an imbalance of inflammation and breakdown as opposed to repair. That leads to bone spurs, degenerative meniscus tear, and we'll talk about edema or changes in the bone. So what we're talking about is very new and somewhat controversial and threatening in a conservative medical field. But this is not new historically. There was a great story from Lani Johnson, who's an orthopedic surgeon who was one of the first to introduce arthroscopy, which revolutionized orthopedists. He was shunned from medical societies and called a quack, and 10 years later he received a Lifetime Achievement Award. So we have to put that into perspective with cellular medicine. Lucio Barato is an Italian doctor who created LASIK and also was shunned from societies and ultimately revolutionized eye care. So when we look at joint pain, there are three environments. There's within the joint, as you can see here, the synovial fluid, the black within the ultrasound. I'm just going to grab this pointer. And the black is fluid that you can see here. There's the bone that we're learning a lot about called subchondral bone. It's like the floor, the cement beneath the cartilage. And then the superficial area is all the nerves, ligaments, and tendons. So perhaps we need to rethink arthritis, that it's more of a disease of bone than cartilage itself. In a review found when you looked at the MRIs and x-rays, often it didn't correlate well with the patient's function. So someone would have mild arthritis yet had severe pain, and others have severe findings on MRI and are active in surfing. This was more correlated than fluid as well. If you have that bone marrow edema, that bright signal on an MRI, it's the strongest predictor of requiring a knee replacement. And many of the radiologists in our community don't even comment on this when reading an MRI. So part of our collaboration is finding scientists from around the world, and we reached out to Dr. Henning Madry, and this is a really cool visualization showing this is your cartilage, and beneath it you can see subchondral bone. And this is the actual channel. It's avascular, meaning there's no blood flow in the cartilage, and this directly connects to the subchondral bone and cartilage. And so we're targeting this therapeutically. And when we look at it histologically in a microscope, you find that these cracks in the bone are similar to microfracture or non-union fracture. So perhaps we need to start treating arthritis as if it's a fracture itself. And so you can see this combination here, this orchestra between synovial fluid, subchondral bone, and all the proteins and growth factors. So Dr. Shapiro went over it well, and unfortunately this is a rather light talk scientifically in the 15 minutes we have. But this is the overview here of some present biologics that may be at the disposal of the current physician. You have hyaluronic acid, which is a sticky viscous lubricant like a WD-40. It's regulated and covered by insurance. You do a series of 4 to 5 or even a one-time injection that lasts for 6 months and helps with mild to moderate arthritis in active people. And then you have the first bedside autologous from the own patient's blood, PRP, and Dr. Shapiro went through that, where you take the patient's blood, spin it, isolate healing proteins called growth factor. It's actually very basic and primitive, and years later we'll laugh at how basic this was, which is this complex milieu or soup of over 1,500 different proteins. And it varies how you prepare it and when you implement it, but nonetheless safe in our first introduction to biologics. Bone marrow concentrate, which Dr. Shapiro went through that I'm not going to go into too much, but removing marrow from the patient's own iliac crest concentrating it and re-injecting it. You have adipose-derived cells, which was mentioned, and I won't get into too much. However, there are some regulatory gray zones and clarity needed, but a lot of promise loaded with regenerative cells. And lastly, you have amniotic fluid, which also has some regulatory clarities to come about, although has great promise as an off-the-shelf injectable, perhaps for seniors or those with compromised immune system where cell therapies from their own bodies may not help. This is a great visual that shows the premise of these autologous therapies. Not sexy rocket science when you think about it. You're taking blood or bone marrow, you're putting it in a machine, a centrifuge like a record player, and what you're getting here are cell densities, so they weigh differently. The red cells are heavy, so they're going to sit to the bottom of the test tube. And then you have your plasma, the yellow in the middle, and the middle is the monocyte, and this refers to the bone marrow. And that's where your rich regenerative cells are. Interestingly, marrow has very few MSCs, or we now refer to them as well as medicinal signaling cells, per Dr. Kaplan, who's speaking this week. And then we're concentrating them and then re-injecting them. And it's the same premise with PRP. This is your buffy coat of platelets. So I'm going to briefly touch about some case reports, which just shows how we use these in the clinical setting. And it also speaks to a worldwide standard of care, which greatly needs to improve. You know, we see a lot of multi-million-dollar athletes that are of great value to their clubs, and they're still receiving suboptimal, outdated care. So this is a case of an elite soccer player who came to us from Brazil. And he had pain at his fibular head, which is the area on the outside of your knee. And it was severe, and he continued to play through the pain. And then after 4 weeks, he had an MRI, and he was diagnosed with this fracture that you can see the break in the bone. And so they had conservative therapy, and he rested for 4 weeks' time. Without repeating imaging, he was feeling a bit better, but not perfect. He returned to play. He then developed what's called tendinosis of the bicep tendon, which is the end of your hamstring. Basically, it's a chronic thickening, scarring, chronic tendinitis, which required 4 cortisone injections to get him through the season and World Cup play. Eventually, after the side effects of cortisone, he had a near rupture of his distal bicep femoris tendon and continued to have a non-union fracture of his fibular head. And so he presented to us, in some of these cases, people come with unrealistic expectations. He's coming in for 1 day, and I don't have magic pixie dust. How can I help this individual? And so in this case, we elected to do bone marrow concentrate, and this is the ultrasound. The black is still the hematoma, which is like coagulated red blood cells. We aspirated or removed it, and then we re-injected it. And here you can see this linear line. This is the crack. You can actually see fracture on ultrasound. And we took an 18-gauge needle, and we dug out the callus, which is the non-healed scar, and we injected the bone marrow within it. And this patient did very well and has returned to play at a very high level after he had failed and plateaued in the off-season. This is another case of a professional basketball player last season who had a severe contact trauma here. And this occurred just before our playoff season. And so this resulted in a dramatic hematoma, basically swelling of blood in the medial calf, which can take many weeks to heal. And so this is the MRI, and the fluid here shows the swelling within the calf. You can clearly see that. And then we saw him 2 weeks after failing conservative treatment. He basically was limping, had plateaued, no progress, and playoffs were coming in 2 weeks' time. And so you can see nicely here in cross-section the medial gastroc, lateral, and this is the large hematoma. And so what we did was we aspirated, we stuck a needle under ultrasound into his calf. We'll see if it works. You can see here. And this was very arduous, that the blood had coagulated. And so I had to use 3 cc small syringes, and I aspirated 92 milliliters of blood from his calf. And what we had to do was push saline through the tip of the syringe because it kept clotting. So this took about a half hour for the procedure. We removed all the fluid, and then we replaced it with a PRP that contained no red blood cells and no white cells. The premise is the wound is stuck. It's filled with a disproportionate amount of red cells. So you want to replace it with platelets and growth factor. So he received a second aspiration a week later with 40 milliliters left. And then 2 weeks from his initial procedure, played throughout the playoffs with no setbacks and has no recurrent injury. So lastly, in part of collaboration, we launched a outpatient surgery center in Beverly Hills. And it really works the amount of people in here. We often have 4 doctors working together on patients, between an anesthesiologist, an individual expressing bone marrow, a doctor like myself injecting the marrow, and an orthopedic surgeon. We're integrating new technology where we use a pediatric arthroscope. So it's made for children. And what's nice is you insert it into a joint, and there's no sutures or stitches required. And you can look and see the cartilage. You can wash the knee to create a nice environment, and then inject your cells directly where you want to. And so you can see here the potholes or cartilage lesions. And so future research is not only in fat versus bone marrow versus PRP and what's the ideal cell, it's also how do you deliver that cell? Do we create a paste? Now we can create fibrin glue and patch this. Do we drill beneath the bone as we talked about? So this just shows a case here of a man in his mid-40s that clearly sees any standard orthopedic surgeon warrants a hip arthroplasty, a total joint. The problem is he's in his 40s. Those joints aren't going to last forever, and these patients are active. And so we drilled and injected interosseous under X-ray. You can see the areas, the acetabulum and the femur. And we're following these patients at 3 months, 6 months, and 12 months. But keep in mind, these are really severe cases trying this, understanding this may not work, but if you want to look back and try to avoid what you can with an arthroplasty, it's an option. This is a knee showing how the needle goes into the bone, and this is the T2 fat-suppressed image here, what we target, which is like pouring water on wood. It's very soft and porous. This is an ankle with an osteochondral lesion that we inject as well. So in summarizing, arthritis is an epidemic, and it's really important to get the word out. It's not just a disease of time and seniors. It's really a disease of activity and trauma. The more people are active, the more we're going to see arthritis, and there's really terrible, poor options that don't target the disease. PRP and bone marrow, we believe, modify the environment of the cells and can neutralize OA. We're not able to get the holy grail and regenerate cartilage. We need more studies and collaborate to better understand these cells as well as how to deliver them. But we're seeing more and more major institutions, the US Army, all our academic associations are now really looking at stem cells and seeing the promise. This is part of history. We should be excited, but we also have a diligence, as was mentioned earlier from the FDA, to police our work and make sure we're putting out good science. And I encourage people to consider coming to our meeting in Las Vegas in June, which has workshops and cadaver labs and really brings together some of the best in the world. Thank you very much.
All right, thanks, Dr. Sampson. That was fantastic. Dr. Sampson really has helped pioneer over the last couple of years regenerative medicine techniques in orthopedics and sports medicine. So I'm going to open it up now. We're going to do a question and answer session, but I'm going to start off the question and answers by reintroducing our other 2 panelists, Ron Courson, the Director of Sports Medicine at the University of Georgia, and Malcolm Mitchell. So my first question, Ron, for you guys on the front line, you're managing athletes on a daily basis, and clearly there's some areas where conventional sports medicine and conventional orthopedics falls short. What would you say holds the most promise? Where is the most need in sports medicine for the future of regenerative medicine?
I think this is a very unique and emerging field. One of the things we have to think about is I'm dealing with athletes that are the ages of 18 to 22, and we want to think about not only what's best for them right now, but also look for them down the road. And it was mentioned in both the talks, we're seeing an epidemic now of osteoarthritis in patients that are 35, 40 years old, many times from injuries that may have been mismanaged or not managed appropriately earlier on. It's not uncommon for us now to have an 18-year-old freshman come in that may have had an ACL reconstruction 3 years before and already has significant degeneration in their knee. So one of the things we want to try to look at now is, are there ways and techniques we can use to try to regenerate and let the body heal itself perhaps in a better way. We started using biologics in 2009, initially more hyaluronic acid and PRP, and in the last year and a half, Jim Andrews is a good friend of mine and a colleague, and we've started moving into some limited cases with stem cell, and feel like we've got some very good results.
So Malcolm, you're who we're doing this all for, right? And what we'd love to hear your perspective as an athlete on what it's like when you sustain an injury and when you're seeking medical care, trying to get back out onto the field of competition. What are some of your concerns that you had going through this process, and even if you're willing to tell us a little bit about your firsthand experience from personal injuries?
I think the first thing we should understand is anytime an athlete at this level sustains a severe injury, it's detrimental to their life. They're afraid, because this is what I've always wanted to do. I want to achieve my goals in athletics, and when I get injured, a moment of doubt appears. And when that happens, I have to have somebody to call on that I can trust, that can put me in the best situations to get back out there. And I think that's why Courson is so important to us, and as every athletic trainer at their respectable places. I think one of the major concerns, definitely when going into the process, would be making sure that you're taking the necessary steps to progress, that during the process you don't have any setbacks. And I think for me personally, I just wanted to take out the time. I know we did a lot of research trying to figure out what would work, what wouldn't work. We tried things did work, things did not work. But just going through that process itself and figuring out what can really help was definitely important.
Terrific. So we've only got one microphone. I'll take questions from the audience if you have any, and you can stand up and ask the question, and then I'll repeat it. So my understanding of the Mimetics company is that they're an amniotic derived product. They've used amniotic cells for a number of different medical applications, one being wound healing, and certainly hold the promise of using those same cells to repair injured tendon, possibly repair cartilage, repair bone, so on and so forth. All of those products need to go through the process that Dr. Sampson and I both alluded to in the talks. I think we have a fairly clear pathway to market for those things now, and we all just have to go through those steps. The director of the FDA this morning mentioned the cost to bring a product like that to market, and it's extraordinarily expensive. But that's what has to be done, because public safety is what's at stake here, and it's the FDA's job, and us as scientists, our job to protect the public and make sure that the treatments that we come up with are not only efficacious but also safe. So I like all the theory behind all of that, and I want to see it in action. That's what I typically say as a clinician.
Yeah, I would just add, in general, the model of wound healing is relevant to cartilage, bone, tendon, spine, nerve, and a lot of the origins of PRP, the first generation biologic, came from wound healing. So there's some promise there, clearly. There's at least 4 or 5 players in the amniotic space that have been making a big push in the last 12 months, despite still some gray regulatory clarification on it. But the concept is they're not live stem cells from amniotic fluid that are being administered to patients. The hope or promise, or at least what I understand, is that it's the way they communicate with your body cells to turn them on and program them to regenerate themselves. But there's also very limited studies orthopedically, and sometimes we get in a situation where patients are very vulnerable and they just want to get back on the field, and doctors are being informed by pharmaceutical reps that have a self-interest. So as the doctor, we have our own obligation to really weigh the science. But the challenge is a lot of these trials are the gold standard of the randomized controlled trial we've all grown to go by, are very challenging when they said it cost $2.4 billion in 10 to 14 years. By the time something innovative is invented, it's too late. We've all got arthroplasty. So it's a challenge where you have to get some clinical data that you can hold your hat on and be comfortable with, So it's an interesting space that's going to continue to evolve as regards to amniotic fluid. Yeah, thank you. Those are some great comments. And much like PRP, we first thought you just take the patient's blood and spin it down and re-inject it. And about 8 years later now, we've realized there's so many more levels of PRP, whether it's if it includes white blood cells, red blood cells, if it's activated, what the concentration is. And my colleagues, some of which are here, published a standard classification paper. And so the same goes with amniotic fluid, and that each manufacturer and each product is different, very different. Some have amnion, some have chorion, some may cause an inflammatory reaction, and there's a debate regarding the live cells, as was mentioned as well. But in general, we do need to improve this standardization of not only the processing of the cells, but how we deliver them and make sure that they're safe, and really educate our patients. I tell them with any medical procedure, when I stick a needle in you, there's a risk that includes infection, fever, worsened pain, no relief. And generally, I set the bar low for these patients. It's challenging. They failed everything already. But it's nice in that bone marrow has a natural peptide, LR77, that is antibacterial, which makes it very safe, as well as amniotic fluid has some antibacterial properties, as well as PRP.
Yeah, and the prevailing theme there through your comments also is that we are simply in our infancy in understanding all of this, and regardless of what product you point at, we don't know what we don't know. And so specifically to comment on the amniotic products, I very much look forward to the level 1 studies that ought to come out of the companies that are promoting this. I'm a clinician, I'm not a basic scientist, but we just completed a randomized, placebo-controlled, blinded trial of bone marrow aspiration and concentration for osteoarthritis. And we were able to get it done in about 1.5 years, and it's expensive, but it's not overwhelmingly expensive, and any company that is promoting a product to go through this process can do the exact same thing, and we would love to see that. We would love to see that data, and we'd love to have that product available for our use so that we can begin trialing it as well. You guys said you did your homework when you were looking for these things. What's it like to be a patient doing your research and not being quite sure about everything that you're being told?
It definitely draws a lot of concern as far as anytime you research a certain product and you realize that it's foreign to the body, something that the body naturally doesn't make itself, and then you're injecting it, because then you're very uncertain about the reaction you're going to have. I know for the hyaluronic acid, when it was injected into me, the reaction was a lot different than expected. So it's just kind of trial and error, knowing what will work and what won't work. But for me, once there was something out there that I seen that was natural, that the body produced on its own, that you could inject in, it kind of lowered that risk for me.
I think one of the things we need to keep in mind as well is we all want patient-centered medicine. What is always best for the patient, and particularly in sports medicine, I think we've got to do a very good job of making sure we educate our athletes about risk and benefits of every procedure we do. It's inherent many times in athletics. They want to be very aggressive in the treatment philosophy, and many times they want to go full bore for the first thing they see or hear about. And I think sometimes we need to sit back and sit down and counsel them and say, hey, these are the best options you have. Explain the risks and benefits of each one, and then pick as a group what we feel is the very best for them. But we always want to emphasize patient-centered medicine.
And I would just add a little story, too. When treating professional athletes, they're under a great deal of pressure financially to get back in the game. They'll lose revenue. A younger player may take their spot. And so we had treated one NBA basketball player with a knee tendon, patellar tendinosis, which is like a chronic tendon pain beneath your kneecap. And PRP can be helpful in the right circumstances, but it takes several weeks to months. And so educating the patients is really important to explain what to expect. So I had treated this patient, and then just about 2.5 weeks later, I ran into another colleague, and he told me that that patient he had just treated and gone with him to Germany for another treatment. And so sometimes people are over-treating themselves and making irrational decisions. that we just have to be mindful of as well and be responsible as the doc to really educate patients. We did one of the world's largest tennis elbow studies that was a multi-center placebo-controlled trial in AJSM with my colleague Alan Mishra that many still aren't even aware of. It kind of went right under the radar. We tend to like controversy, and any bad study gets a lot of press. But what it showed was it took between 4 to 8 weeks for these elbow patients to start feeling better. And then between 4 to 6 months, we saw a dramatic change versus placebo. And so we tell our patients, if you're going to do something like PRP for a chronic injury, you have to wave the surrender flag and realize this is going to take weeks to months to improve rather than look for a quick fix.
Well put, and I want to just echo what Malcolm just said about trial and error. I mean, that's uncomfortable for the patient, that's uncomfortable for the clinician. We really want to hammer down on which of these treatments works, which don't work, and what are the protocols that we need to use in order to deliver those treatments to our patients. Any others? Yeah. So obviously all the autologous treatments are for the individual patient. The cells are taken from the patient and redelivered back to the same patient. As far as young versus old, what I would tell you, and what I'm sure Dr. Sampson would tell you, is those two very much bleed or blend together. That newspaper article I showed you from the New York Times was from February of 2008 or 2009, and that was brought into me by a patient who had read about those two Pittsburgh Steelers treated in the Super Bowl. And one day later, the patient's in my office, and he was 86 years old with a rotator cuff tear and said, "I'll take this treatment, please." So we're talking about young and old. We're talking about athletes, high-level athletes, weekend warriors, and then those that used to be high-level athletes and weekend warriors, and now have the chronic downstream degenerative results of those. So that's for the autologous treatments. As for the pharmaceutical products, those are all presumably created from cell lines. They harvest the master cell line, and you have to have good manufacturing practices as mandated in any drug manufacturing process. And so, that's an entirely separate issue from the autologous treatments that we're using. It's a good question, though.
Thanks. And while we do know that the patient's autologous stem cells and their function decline with time, interestingly, when we collected our data, we collect data on all our patients, and we'll be publishing a retrospective on 125 cases. Age had no bearing on functional outcome up to 79, which is pretty fascinating. And our colleagues that also have a registry data similarly found, this is regards to bone marrow, that the age did not factor in. For us as clinicians, what's perhaps a greater variable is the overall lifestyle and activity level of the patient. I always tell my patients I would much rather treat an active individual with advanced arthritis, so they're walking, they're exercising, they're getting out of the house, they're somewhat healthy, as opposed to a sedentary individual. And then another caveat is we found statistically significant trends towards those with a higher BMI, so those that were heavier, had more fat, actually responded more favorably when they did their bone marrow than those with a lower BMI. So it's something to think about and questions to answer. But by no means is bone marrow a magic pixie dust and, oh, you're a senior, this will work great. You really have to determine if it's the appropriate option. But some of these people, they're not good candidates for arthroplasty. Do you just live with the pain, or are you willing to try something if we feel is safe? It may not work for you. There's a 50% chance. Can you live with that? That's up to the patient.
Well, let me start by saying that we're not all convinced, as Dr. Sampson mentioned in his talk, that the MSC is even the building block, that's the mechanism. I think perhaps we all thought that when we started. We've got stem cells, and now we're going to build new cartilage or build new ACL. There's plenty of evidence now that suggests, as you quoted Dr. Kaplan, is relabeled the MSC, the mesenchymal signaling cell, or the medicinal signaling cell. And so maybe the number doesn't matter at all. And I can tell you from our study, and we used the markers recommended by ISCT and the FDA to count ours, and our average or median number of stem cells from a 60 ml bone marrow aspirate was between 40,000 and 100,000, and compare that to the millions that you can get from culture expanded, and yet we had fairly dramatic results from our patients. And I don't want to report anecdotal examples, but just as you have had patients who have gone on to do amazing things, we've taken patients who, again, this was a blinded study, and they don't know what they were treated with, and many of them much more active than they were when they started, much less pain, and again, just as you said, very, very low stem cell numbers. So there's so much to be learned about what's actually in that soup that may be so much more than the stem cell. Maybe the signaling cells are stimulating native stem cell populations to get back in the game and do what they're supposed to do. Yeah.
Yeah, those are all spot-on points. The immune system and the underlying health of the patient's critical to have the capacity to heal and self-repair. There's also debate on not only the technique and how you pull the marrow, whether it's from one site, 2 crests. Hernigau, who we had at our TOBI conference in June, pulls from at least 10 sites of the iliac crest with really quick draws and using 10 cc syringes showing higher cell yields. And then there's debate, do more cells matter? And everything's bigger and better in this country. And Hernigau actually has published rotator cuff tears, and then he'll actually, instead of just repairing the cuff, he drills, like I do in the knee, he drills into the humeral head. And they biopsied and studied the humeral head and rotator cuff tears and found that it was void or deficient of stem cells. And so he calculated the average amount of cells in a humeral head and those that were missing, and comes up with a dose. And now there's debate if that matters, because those like Dr. Shapiro and myself, aren't getting those high level of cells yet. In the real world, our patients are feeling better. So that's to be clarified.
And one, to your point though, this is important to get out there for people that are looking for these techniques, people who are going to be using them. I don't think it's fair to let people think, I've got a stem cell, so I've got new cartilage for you, or I've got a stem cell and I've got new ACL. It's very hard to have that conversation with people, and anybody that comes in asking us for this treatment, we always have that long conversation. It's a hard one to have because it's a biochemistry conversation, but very important that we start telling our patients, no, stem cells may not necessarily just regrow that which you need regrown. They may be just part of the process. Well, I'll answer the first part of that by telling you when we did our study, it was FDA regulated, so we applied for and received an IND. And the FDA had their own thoughts about what we should be looking at in terms of safety. And so those were the simple things that any clinician, any athletic trainer would be using in their regular practice as part of the medical care with the medical team. So simple things like CBCs and liver function tests and renal function. Yeah. Right. So the problem with that, and Dr. Sampson hinted at this, that there are numbers of markers that we can look at in synovial fluid, in serum, and whatnot. They're very expensive. They're very expensive, and we conducted this trial, and it cost a lot of money to look at those things. If you're in private practice and you're offering this to a patient who may be paying out of pocket for this, the insurance company's not going to pay for those markers. They're not even offered by most standard laboratories, so you almost don't have access to them outside of a clinical trial. And I agree with you; it's a big problem because we want to look at this. Yeah, that's all well said. And just to repeat, because I think I've been doing a bad job of repeating the questions, but that was more of a statement about the need to change how orthopedic research is funded and bring together the interested stakeholders, clinicians, scientists, patient advocate groups. That's the purpose of the World Stem Cell Summit, right?
Yeah, and I would just add on top of that, some of the challenges is things like PRP are not a real moneymaker for big pharma, and it's often driven by patients. And so since the work has outpaced the science, so to speak, since the Heinz Ward press and Tiger Woods and became very sexy and popular, and patients were going to their doctors, I want this, and doctors first poo-pooed it, and then it kept coming and coming, and there was some good papers and some bad papers and learning about PRP, and they're forced to really have an educated opinion, but the standard clinician that's performing these doesn't have the knowledge, capacity, funding to do widespread clinical trials. I do it on top of seeing patients, and it's very laborious, and it makes you crazy, and it takes 2.5 years to get your data. We're publishing data from 2012 coming out soon. And then you try to pull teeth to get funding, and they're not large orthopedic companies throwing money at this. It's smaller mom and pop biologic companies. So it's a challenge. The key would be to all collaborate and find ways to get that funding, because ultimately it will benefit the patients.
All right, last one, because we've well run over our time allotted. So the question is, what's the plan going forward, and how to get these trials done? Well, I think first of all, you got to put together a good team, and that's one of the ways that we got started. And having completed our first trial and on the way with our second trial, once the pieces are all in place, then the steps that you've got to go through. We've dealt with the FDA once. We can do it again, and we've all worked together. So there's that. The other the other thing that I would say, and I don't know if this is good or bad, but you're probably going to have to keep your patient numbers low. It's very hard to randomize this with hundreds of patients because you're dealing with cellular material and surgical techniques. It's hard to collaborate across institutions where I do 10, someone else does 10. So it's very challenging. So you start with the basics. You do pilot studies. We make them as high quality as we possibly can, and then we open them up to scientific scrutiny, and then we see where we go from there, and then you hope that the people who are performing these procedures outside of clinical research do so in a responsible manner, keeping in mind patient safety and the overall well-being of the patients. All right, thanks to a fantastic panel. Thank you to the organizers.